All right, now moving on forward with our next set of questions. Let's see question number 80. What is the gold standard for diagnosis of PID? Now the answer to this question is diagnostic laparoscopy. You see all of these features, clinical triad of pain, fever, cervical tenderness, ultrasound, even option A and option D are symptoms of and diagnostic findings of PID can be seen on ultrasound as well. Between histological confirmation of endometritis versus diagnostic laparoscopy, both are the definitive criteria, but if you have to choose one, we will go for diagnostic laparoscopy. Because why? Because PID mainly infects the tubes, right? It affects the endometrium less often than it does affect the tube. Then it does affect the endometrium. So in PID, what happens is that tubal involvement is more common than endometrial involvement, right? That is why diagnostic laparoscopy will be able to tell us about the tubal involvement. If we do the histological confirmation of endometritis might not be there as a routine finding in PID all the time. However, both are definitive criteria. So let's just understand what is PID and what are the definitive criteria and what are the minimum criteria. So whenever we have PID, whenever we talk about PID, we mean infection of the endometrium, we mean endometritis, we mean salpingitis, right? And we mean oophorytis, right? Out of all these things, and PID can also, move ahead and lead to pelvic peritonitis later on, then that is pelvic inflammatory disease. Out of this, salpingitis is the most common manifestation. Tubes are usually involved, and when we talk about the most common cause of PID in reproductive age group females, we realize that earlier it was gonorrhea, but now the trend has changed. Nowadays, gonorrhea has become much less common. We are now having PID because of chlamydia. Now this chlamydia is very notorious, it is very bad. Why? Because 80% of the times the infection with chlamydia is actually asymptomatic, right? So it is not found out, and ultimately extensive tubal damage can result with chlamydial PID. And sometimes with PID there is also associated with perihepatic adhesions. This is an important point. Perihepatic adhesions, sometimes this can be associated with perihepatic adhesions, then that is called as Fitzhugh-Curtis syndrome. Now Fitzhugh-Curtis syndrome is perihepatic adhesions, and the causative agents could be chlamydia, could be gonorrhea, could be tuberculosis, whatever, but important thing to remember is that it refers to perihepatic adhesions, which is Fitzhugh-Curtis syndrome. It is seen sometimes in PID, right? The most common cause in reproductive females becomes chlamydia. Now we understand that PID will not be very common in virgin females, women who are not sexually active as of yet, right? So young adolescent girls who are not sexually active, if they have PID in virgin females sometimes, then during that time we should not suspect chlamydia, we have tuberculosis as the cause of that PID. Tuberculosis as the cause of that PID. So through three important points to remember here, additional points to remember about PID, the organism responsible with respect to age. Now criteria for diagnosis of PID, we have a minimum criteria, we have an additional criteria which helps in making the diagnosis, and we have a definitive criteria for the diagnosis of PID. Now minimum criteria is based upon the physical findings. All right, a PID woman can present with discharge, can present with pain abdomen. The minimum criteria is cervical motion tenderness, uterine tenderness, and adnexal mass, right, and adnexal mass. Now the additional criteria on the other hand could be fever, it could be vaginal discharge, it could be WBCs in the vaginal discharge, elevated ESR, and lab documentation of chlamydia or gonorrhea, right, in the vaginal discharge. Lab documentation of chlamydia or gonorrhea in the vaginal discharge is just an additional finding, all right. So it is not a definitive criteria. Important point is, what is the definitive criteria? The definitive criteria is laparoscopic findings. So laparoscopic findings will be tubal findings, will be perihepatic additions, will be pyosalpinx or tubo or pyosalpinx could be there could be hydrosalpinx, there could be perihepatic additions or additions in the pelvis. So those are the laparoscopic findings we're talking about. And second is histological evidence of endometritis, right, that is also a definitive finding. And another definitive criteria is tubo-ovarian abscess on USG, tubo-ovarian abscess on USG. Now it is in this order that out of these definitive criterias, if we have to choose one, then we will choose laparoscopic findings, because I told you that the tubes are the one which are most commonly involved in PID. Now another important aspect of PID you should remember is treatment. Very importantly, whenever we have the OPD treatment, for, let's say, chronic PID, when the woman is symptomatic but she is not in an acute stage, then OPD treatment needs to cover chlamydia as well as gonorrhea. Now the treatment of choice here is, remember, treatment of choice here is ceftriaxone 250 milligrams IM single dose plus doxycycline 100 milligrams BD plus minus metronidazole. Right. So when we talk about chronic PID, we have to treat with ceftriaxone single dose and doxycycline plus minus metronidazole. All right. When we give inpatient treatment with acute PID, we can give the same antibiotics, but we might give a broad spectrum antibiotics, but initial treatment has to be IV drugs. So with acute PID, the initial treatment has to be IV medication, and IV medication can be given. We can have cefoxitin, doxycycline also in the IV dosages we can have, but what we have to remember that it has to be broad spectrum. So broad spectrum antibiotics are given in acute PID in IV, and this doxycycline is given for 14 days. This metronidazole should be given for 7 days, right? So this is the treatment in acute and chronic PID. But if they ask you specifically with cervicitis, chlamydia, cervicitis, when we talk about cervicitis, we have to take care of chlamydia and we also have to take care of gonorrhea. So something which is called as the syndromic approach when we deal with cervicitis. When the cervicitis is different from PID, all right. In PID, the minimum criteria is there. In cervicitis, there is only infection of the cervix with no other findings suggestive of PID. So whenever we have cervicitis, we give an empiric treatment. We cover chlamydia, gonorrhea, and here the treatment of choice becomes ceftriaxone 250 milligrams IM single dose plus azithromycin 1 gram single dose oral. Okay, so this takes care of our gonorrhea as well as our ceftriaxone is effective against gonorrhea, azithromycin is effective against chlamydial organisms. So this can be there given as the treatment. Now moving on to the next question. Question number 81. Fetal hydrops is most commonly associated with, the answer to this question is cardiac anomalies. Alright, cardiac anomalies are the anomalies which are most commonly associated with fetal hydrops among all the anomalies. Now I will just give you a few important points about fetal hydrops, what you should remember about fetal hydrops. Now fetal hydrops importantly can be immune or it can be the non-immune types, right? Now we know that the immune fetal hydrops is more commoner than the non-immune type. This is more commoner, and when we talk about immune, we understand it has got to deal with RH incompatibility between the mother and the fetus, which leads to fetal hemolysis and fetal anemia. Right, fetal hemolysis leads to fetal anemia, and that when the anemia becomes very severe, that means when the hematocrit falls below 15% and the hemoglobin has fallen below 5 gram%, it results in fetal hydrops. Okay, it results in fetal hydrops. So fetal hydrops is not always a feature of anemia, it will be a feature with severe fetal anemia when the hematocrit falls below 15% and hemoglobin falls below 5%, it results in hydrops. Now how do we diagnose this hydrops? The diagnosis of hydrops is done by ultrasound features. So in the ultrasound there has to be fluid in 2 spaces, or there is fluid in 1 space plus anasarca. Okay, so either there has to be fluid in 2 spaces or there has to be fluid in 1 space plus anasarca. Now what are these spaces we are talking about? We are talking about pleural effusion, we are talking about pericardial effusion of the fetus, okay, a pericardial effusion, we are talking about ascites in the fetus. Alright, these are the 3 spaces, and anasarca. Sometimes they have asked this question, what is Buddha's sign? Now Buddha's sign is basically also called as the halo sign. This is seen with fetal hydrops. It is basically scalp edema that happens, and that leads to Buddha sign or halo sign on ultrasound. That is called found in hydrops. Another important point is there are features which are associated with hydrops but not diagnostic of hydrops. So there are the features which are associated with hydrops but not diagnostic of hydrops. They are polyhydramnios, and there is placentomegaly. Okay, and there is placentomegaly. These are other features which are associated with hydrops. Now coming to the non-immune hydrops. Now this non-immune hydrops, if you were to say, if I were to ask you overall the most common cause of non-immune hydrops, okay, overall the most common cause of non-immune hydrops would be cardiac anomalies in the fetus, okay, cardiac anomalies in fetus. When I mean overall, means I am considering fetuses which are born with hydrops, live born fetuses with hydrops, stillbirth fetuses with hydrops. I am considering overall all the presentations of hydrops, right? So cardiac anomalies in the fetus are the most common overall cause of non-immune hydrops. If hydrops is identified antenatally, right, especially in the 2nd trimester, then the most common cause is aneuploidy. And if there is hydrops in the 1st trimester itself, then the most common cause is Turner syndrome. Okay, so what do we learn? We understand that immune hydrops, when develops, it usually develops after after 18 to 20 weeks of pregnancy. Before that, it does not develop. Immune hydrops because of RH incompatibility usually will happen beyond 18 weeks of gestation, all right, because up till 18 weeks the fetal reticuloendothelium is not mature enough to mount a hemolytic response, right. Therefore, hemolysis and anemia does not usually happen in a fetus who is less than 18 weeks, all right, even with RH incompatibility, even with RH immunization, so 18 weeks, right. So that is why they say if hydrops is antenatally identified, especially in the second trimester, the most common cause is aneuploidy. If hydrops is identified in the first trimester, the most common cause is Turner syndrome. But overall, the most common cause of non-immune hydrops is cardiac anomalies, right. So if they have not specified anything, then it is cardiac anomalies, but if they specifically ask you antenatally diagnosed or diagnosed in first trimester, these are the most common causes. Then other causes are obviously infections is another cause, and among all the intrauterine in utero infections, parvovirus B19 is the most common. All right, so infections can be many in utero infections, but among all those infections, parvovirus B19 is the most common. Now, moving on to the next question. All right. Now, this part, let me tell you, in this session now, this time round, we are going to talk about much of the focus in this half would be oncology. So I would try to, because oncology is a huge topic, it becomes very challenging to compress all the important points of oncology in a 2-hour session or whatever, so that we will go through the important aspects of the oncology bit here. Now let us talk about the question number 82 here. The best investigation to diagnose a CA cervix in early stages is a pap smear. Now see, to diagnose anything in early stages, what are they in a nutshell, what are they wanting to ask? They are asking screening. They are asking screening method to diagnose early diagnosis. If we, this is like PSM now, right? Early diagnosis and treatment. Early diagnosis and treatment is achieved by screening. So among all these methods here, the screening method here is pap smear. The best screening method, the screening method among all these methods is the pap smear. So that is why here in question number 82, the answer is pap smear. All right, because this is the screening method, early diagnosis and treatment. Screening is a part of early diagnosis and treatment. So screening method among all this is the pap smear. Now screening for cervical cancer and CIN. When we screen apparently healthy women, right? Screening is always of apparently healthy people. So apparently healthy women, when screened, they are subjected to a number of tests, and those tests are frequently repeated to diagnose CIN, cervical intraepithelial neoplasia. So now I will give you a brief overview about cervical cancer screening. All right, now I want to here to give you a brief overview about the cervical cancer screening. Now when we talk about cervical cancer screening, what are the methods available to us? From traditional, and for years we have had the pap smear. Now we have now we have HPV DNA testing, right, and we used in combination with the pap smear, and then we call it as a co-test, right. So when we combined HPV DNA testing with pap smear, when these two are combined, we call it as the co-testing, right. Now not yet a part of the protocol, but primary HPV DNA testing is also being evaluated as a method of cervical cancer screening without doing the pap smear. It is something we will not go into the details as of now, but we'll consider each of these tests one by one. And apart from that, for cervical cancer screening in low resource countries like India, not all the cities in India are low resource cities, we have villages, we have PHCs, we have CHCs where pathologists might not be available, where apparatus to do microbiology lab might not be available. So those are the situations where low resource settings where we can use other tests like the visual inspection of acetic acid, visual inspection of acetic acid, in which cervix is just the ectocervix is just dabbed with 5% acetic acid and the abnormal area turns white, and then that area can either be biopsied in the same sitting, which is called as in which we are not doing any colposcopy, we are directly biopsying, or we can do just see and treat, which is just see the area and treat with cryotherapy in the same sitting or LEAP in the same sitting. But those are other options available with visual inspection of acetic acid. One option that we can do here is see and treat. See and treat can be done sometimes, but it is not the recommended way to go about it. Another test for screening is the VILI, which is visual inspection with Lugol's iodine, visual inspection with Lugol's iodine, and in this we are using Lugol's iodine. This is also called as Schiller's iodine. Sometimes we can use either Lugol's iodine or Schiller's iodine. Both are just different preparations of iodine. And the abnormal area appears yellow, and the normal area, because of the presence of glycogen, turns brown with iodine, right? And normal area is brown. So this is about the two test: visual inspection of acetic acid and villi, which is visual inspection with Lugol's iodine. Now, considering pap smear and HPV DNA testing, in the pap smear we have two types of pap smears which are available. We have the conventional pap smear and we have the liquid based cytology. Okay, we have conventional pap smear and we have the liquid based cytology. Whenever we have the co-test, whenever we are doing the co-test, we always have to do the liquid based cytology. Co-test cannot be done with conventional. So whenever we have the co-test, we have to use the liquid based cytology. In the conventional pap smears, which we have seen that again, an IR spatula is used to sample the transformation zone. Whenever we are talking about HPV DNA testing or pap smear or visual inspection of acetic acid, what are we sampling? We are sampling the transformation zone. We are concerned about the transformation zone. This is the transformation zone. This transformation zone is actually on the ectocervix. It is here that CIN or cervical cancer arises. So we are concerned with the transformation zone. This transformation zone is nothing but the area on the ectocervix between the old squamocolumnar junction and the new squamocolumnar junction. And so bottom line to remember, as a last minute point to remember, is that it is the transformation zone we are sampling. It is the sample is taken from the ectocervix, right? And this is where the CIN or cervical cancer arises. Now in the conventional, again we are using the IR spatula. We are using the IR spatula to make a slide, and the slide is not allowed to air dry. It is not allowed to air dry, and it is immediately fixed in a fixative, right? Kept immediately inside a fixative, which consists of 95% alcohol, ethanol and 5% ether. This is the fixative, standard fixative, and then staining is done by the pap stain, which is the Pap-Nicolau stain. right? So this is about the conventional pap smear. In the liquid based cytology, we take a sample from the cytobrush, sometimes cytobrush, and that cytobrush we insert again, rotate it in 360-degree manner, and then that is put into another fixative which is used for liquid based cytology. Now the difference between conventional liquid based cytology is that between both these tests, the sensitivity of both methods is the same, right? The only difference is that with liquid based cytology we can go for a pap co-test, which we cannot go with conventional pap smear, and the other difference is with liquid based cytologies there is lesser interference with blood while making the slide, and there is lesser number of unsatisfactory smears, okay, lesser number of unsatisfactory smears. These are the two advantages, these are the two points to remember, that with LBC, the only advantage that LBC offers is a lesser number of unsatisfactory smears. However, the sensitivity of both these tests are the same, right? Now, considering pap smear versus HPV DNA testing, considering pap smear versus HPV DNA testing. Now, pap smear is a single pap smear has a sensitivity of only about 55%. So it is, but the specificity of pap smear is very, very good. It's around 80 to 90%. So that means if a pap smear says abnormal, it is very likely to be abnormal. But if a pap smear says normal or negative pap smear, the sensitivity is only 55%, right? So that is why pap smear needs to be repeated to increase the sensitivity. Therefore, it needs to be repeated at regular intervals. It needs to be repeated at regular intervals to increase the sensitivity. Okay, when we talk about high-risk HPV DNA testing, we have to remember that almost all the women, almost all sexually active women will acquire HPV DNA from their partners during the course of sexual intercourse and during some part of their reproductive lifespan with the onset of sexual activity, right? So HPV DNA is most of the times acquired by all normal sexually active women, right? So HPV DNA infection or HPV infection, first of all, HPV infection is very common in young females, all right? It is very common in young sexually active females, and the point is that 80% of this infection is spontaneously cleared, okay, by the normal immune mechanism, spontaneously cleared in the next 2 years, right? It is the persistent ones, persistent HPV infections which lead to dysplasias, right? So with that logic, we realize that HPV DNA testing is less specific as compared to pap smear, but it is more sensitive, and the sensitivity increases with age, more sensitive, and this is more sensitive especially as age increases, the sensitivity increases, all right? So we realize what are the points of difference? HPV DNA testing is less specific, more sensitive, and very importantly, it has because it's more sensitive, it has a very good negative predictive value, right? So therefore, it can be used with pap smear to increase the interval of screening. Therefore, when used as a co-test, with PAPs, then it can increase the interval of screening. And very importantly, we do not use HPV DNA testing in women less than 30 years of age. So we use this only in women, only in female women more than 30 years of age. We use the HPV DNA testing in the form of co-testing or primary testing, right? Now, so this is one important aspect that you should remember. about H-pap smear versus HPV DNA testing. So this is in a nutshell summarizing pap smear versus HPV DNA testing. Now, what is the screening protocol? Very important to remember what is the screening protocol. Now, this screening protocol is again given by American guidelines. So, the screening protocol says that the screening starts at age 21, irrespective of the onset, age of onset of sexual activity. Second, when we use pap smear, it doesn't matter we use liquid based or conventional, the interval is repeat every 3 years. And when we use the co-test is HPV plus pap smear, then we repeat every 5 years, and co-test can be done when the age is more than 30 years. Other important point is when to stop screening. We stop screening at the age of 65 years if there has been regular screen in the past 10 years. Now, that regular screen in the past 10 years would mean two consecutive normal co-tests or 3 consecutive normal PAPs. That would mean the same thing, that is regular screen in the past 10 years. Very importantly, we can stop screening for women who have undergone total hysterectomy for causes other than CIN or cancer, other than CIN or cervical cancer. So again, screening can be stopped once the woman is age 65 years if she has been regular screening in the past 10 years or she has undergone a total hysterectomy for causes other than CIN or cancer. Very, very important, vaccinated women, even these women should be screened. Vaccinated women should be screened. All right. Now coming to the HPV vaccination, that is again a very, very important topic. HPV vaccination is very, very important. Again, recent questions have been asked regarding HPV vaccination. I'm so sorry, just excuse me with this cough and cold. Anyways, let's begin with this about the HPV vaccination. Now, when we talk about the HPV vaccination, we have 3 vaccines available. We have the bivalent, we have the quadrivalent, and we have the new, which is the 9-valent. All right. Now, in the bivalent one is the Cervarix, the quadrivalent one is the Gardasil. Now, remember that bivalent has only 16 and 18. Now, 16 and 18 are the high risk types. These are the high risk types, and it is only for girls. Then remember the quadrivalent Gardasil has 16, 18, which are high risk types, and the other 2 are 6 and 11. Now, these 6 and 11 are the low risk types, and 16 and 18 are the high risk types. They are also for boys. They are recommended also for boys. However, remember, in Indian scenario, currently we are not vaccinating our boys, all right? We are vaccinating only our girls. So 6 and 11, 16 and 18, it is also for boys. It also has 6 and 11, so we can remember that ways. Also 6, 11, also for boys, and also protects against warts. Also protects against genital warts. right? Now when we have the 9-valent one, remember that 9-valent has 16, 18, 6, 11. In addition to this, there are 5 other types which you have to remember: 31, 33, 45, 52 and 58. Now these are the 9-valent ones which have consist additional strains. Now very important point, this HPV vaccine is an inactivated vaccine. It contains of inactivated capsid proteins, also called as viral like particles. The recommended age is 11 to 12 years. However, it can be given any time between 9 to 26 years. The dosage schedule is 0, 1 to 2 and 6 months. And the Indian Academy of Pediatrics writes that if we are vaccinating at age less than 14 years, then only 2 doses are good enough. And remember that before giving this vaccination, the latest guidelines, they say that we can give to women who have begun their sexual activity also. This has been talked about by the American guidelines. So those are the guidelines which are available to us, that sexual activity has begun. Even if sexual activity has begun, then this vaccination can be given. And we do not test HPV DNA before giving this vaccine. We do not test for HPV DNA before vaccinating. And again, the last point which I reiterate again, that if a woman has received the vaccination, then also she should be screened anyhow. Right now, whatever be the screening method, we can get the pap smear. The pap smear report can be that of normal, it can be LCIL, it can be HiCIL, it can be ASCUS or ASC-H. Alright, now I'll just write it a little bit differently. ASCUS I should write here, ASCUS, and LCIL, HiCIL and ASC-H. So if there is any abnormality in pap smear, they should go for a colposcopy. This colposcopy helps in identifying the area, to biopsy. So that is what happens. And then ultimately also remember about colposcopy, that it helps us see the vascular patterns. And sometimes there can be, what can be abnormal in colposcopy? The abnormality in colposcopy would be white areas, there can be mosaic, and there can be punctations. Okay, these are also simple one-liners that have been asked. And colposcopy just simply refers to seeing the cervix, ectocervix under magnification and highlighting those areas. Again, acetic acid is used. We use acetic acid, we use Lugol's iodine. All these things are used to highlight the area. We get white areas, mosaic punctations, and those areas can be identified to biopsy. And ultimately in the biopsy, we will get the biopsy report of anything. We can get CIN. So CIN is a histopathological diagnosis. Remember, LCIL corresponds to CIN1 and HiCIL corresponds to CIN2 or CIN3. ASC-H is also cannot exclude high grade. Remember, whenever there is a cytology is ASCUS, there are 2 options available. We can repeat after 1 year, or we can do HPV triage. So these are 2 options, but there is no direct colposcopy. We either repeat the test after 1 year, or we do an HPV triage. If HPV comes positive, if high risk HPV comes positive, then we go for a colposcopy. So with ASCUS it is a little bit different. We can either repeat the test or we are doing HPV triage. What is better? Doing HPV triage is better. Alright, now if the biopsy says CIN1, then CIN1 needs not to be treated immediately. CIN is managed conservatively, conservative management, and repeat PAPs yearly. If CIN1 persists for 2 years, then we have to treat, and then the treatment can be done in the form of cryotherapy, right? On the other hand, if it is CIN2 or 3, CIN2 or 3 needs to be treated immediately. There is no conservative management here, and CIN2 and 3 needs to be treated immediately by LEAP, also called as LLETs. Right now, woman's age, there is no hysterectomy for CIN2-3. Even if the woman is 40 years, 50 years, the answer is LEAP, irrespective of age. There is no hysterectomy as far as CIN2-3 is concerned. Answer is never hysterectomy. Answer is never hysterectomy. Okay, so very, very important. Age 35 years, CIN2-3, answer is LEAP. Age 40, family complete, then also the answer is LEAP, it is not hysterectomy. Now the reason for this is that, with CIN1, why are we going for conservative management? Because in CIN1 we understand that 80% of CIN1 is actually going to regress, right? And only about 1% is going to progress to cancer, right? And the remaining 15 to 20% is actually going to progress. So 80% is regressing, so we give that time for 80% to regress in the next 2 years. With CIN2 and 3, we have to remember that with CIN2, 5% progress to cancer and only about 60% regress. But with CIN3, again, around 20% progress to cancer and only 30% will regress, right? Therefore, CIN2-3 needs immediate treatment, whereas CIN1 can be conservatively managed. Now, when we talk about Alright, so this is about CIN and its management. Now, we understand there is also a situation which is called as cone biopsy. Now, how is cone different from the LEAP? Cone biopsy versus LEAP. Now, cone biopsy versus LEAP, you should remember that LEAP is an OPD procedure. LEAP entails less blood loss, and LEAP is a more conservative sort of a surgery, whereas cone biopsy means removal of the entire cone of the cervix up till the internal loss. It needs anesthesia, and it is an OT procedure, and it involves more blood loss, and it involves losing a considerable portion of the cervix. So the issues with fertility and cervical incompetence, they arise more so after cone biopsy versus LEAP, right? So this is the difference. So we understand that cone biopsy has very restricted number of indications where we need to perform cone biopsy. Now I will just want to elaborate here just 5 indications of cone biopsy. Again, this is very important, indications of cone biopsy. So we have to understand that whenever there is all the indications of cone biopsy, remember, cone biopsy is such an extensive procedure, it is always done for high cell. It is never done for a low-grade lesion, all right? It is never done for a low-grade pap smear report. It is always done on suspicion of a high-grade pap smear report. So whenever there is high cell plus unsatisfactory colposcopy. What is unsatisfactory colposcopy? Unsatisfactory colposcopy means inability to see the complete transformation zone. So now we have not seen the complete transformation zone. We do not know where these high cell are coming from, and we want to be certain that we have seen the we have to remove all the high cell lesion possible. Then in that case, high cell with unsatisfactory colposcopy, cone biopsy has to be done instead of LEAP. Secondly, whenever there is high cell on pap smear, and let's say for example colposcopy biopsy showed CIN1. So this is called as discrepancy. This is called as discrepancy between PAPS, colpo and histopath report. Then also a cone biopsy is needed to look for any high grade abnormality on histopathology, because PAPS has a very good specificity. So if PAPS is saying high cell, then obviously there is some area of high grade dysplasia which has been missed on colposcopic biopsy, and therefore there is such discrepancy, we need to go for the cone biopsy. Secondly, again high grade CIN with positive ECC, suspicion of microinvasion. If there is suspicion of microinvasion on cervical biopsy or leap specimen. So we did a leap for CIN 2-3 and final report came out to be suspicious of malignancy, then this microinvasion will only be confirmed, or microinvasive carcinoma can only be diagnosed on cone biopsy completely. So these are the 4 major indications of cone biopsy which you have to remember. So this completes a brief overview about CIN and about cervical cancer screening. And remember, CIN 1 and CIN 2-3 are all histopathological diagnosis. If the histopathological diagnosis says CIN 1, no immediate treatment is required. We can wait, we can follow up for another 2 years. When the CIN persists for 2 years, CIN 1 persists for 2 years, then treatment is done by cryotherapy. CIN 2-3 on the other hand, whenever found, need to be immediately treated by LEAP. There are very limited indications of cone biopsy, and these are those indications. Again, the decision to do a cone biopsy becomes easier when such indications happen in a woman with a completed family. If a woman with a woman who is nulliparous, the choice becomes difficult, and then those are the gray zones which we will not concern ourselves with at present. Now, coming on to the next question. Question number 83. Now, labor I have discussed in one of these sessions here with you in very much in detail, so I will just go through this question in a brief. Internal rotation of fetal head occurs when the head touches the pelvic floor. Alright, so pelvic floor corresponds to the level of the ischial spines. This corresponds to the level of the ischial spines. And it is that at this level that the internal rotation of fetal head takes place. Very importantly, also remember that internal rotation is favored by the average size baby with the normal gynecoid pelvis. And very importantly, the most important factor which favors internal rotation is uterine contractions, right? So with adequate uterine contractions, with an average size baby with gynecoid pelvis, internal rotation is favored. These are the 3 factors which favor internal rotation. So this is important point to remember. Let us move on to the next question, question number 84. A hysterosalpingogram was performed for infertile evaluation and revealed the appearance shown here. What is the diagnosis? Now, the diagnosis of this is biconvate uterus. It cannot be 100% sure that it is biconvate uterus. You have to remember that the differentiation between septate versus biconvate is going to be confirmed on laparoscopy plus hysteroscopy, where we are able to see the internal uterine cavity with 2 cornuas as well as the laparoscopy. On laparoscopy in septate uterus, what will happen? The fundus is going to be intact. In biconvate, what will happen? There is a septa, and there will be a dip in the over the fundus. Now, how in this figure by HSG alone we can say that this is biconvate and not septate? Because the distance, because this angle between the 2 horns is the angle is an obtuse angle. This angle is an obtuse angle, not an acute angle. This angle is an obtuse angle. It is more than 90 degree here in this case, and the distance between the two is more than 4 centimeters, right? So if the distance between the two horns is more than 4 centimeters and it forms an obtuse angle, then the diagnosis is more likely to be a bicornuate uterus than a septate uterus. However, the final confirmation can be done by laparoscopy and hysteroscopy. Moving on to the next question. All right. Now, a woman is exposed to a case of chickenpox 2 days back at 14 weeks of gestation. All right. She does not give history of chickenpox in the past. Now, even though the woman does not give a history of chickenpox in the past, it does not mean that she is susceptible. All right. Why? Because there are times when she could have had the chickenpox infection, but she might have been asymptomatic with it. Therefore, in this case, we have to determine whether she is susceptible or not susceptible. For that, we need to test the mother for antibodies against varicella. That is why this is the answer. Now, let me just give you a brief overview, because a lot of times you've been asking this question even on the online forums about chickenpox in pregnancy. So, let us be clear once and for all that what happens with chickenpox in pregnancy. All right. Chickenpox in pregnancy. Now, there can be two situations. One is a woman has chickenpox in pregnancy, or the woman can have history of contact with a child or with an adult. History of contact with a pregnant woman can have history of contact with chickenpox, or a woman or a person with herpes zoster. All right, whatever be the thing, if the woman is certain that there has been a definitive history of chickenpox, right? She is certain that she has had chickenpox in childhood. Only in those cases we consider her immune, and then nothing needs to be done. If she is immune, then there is no problem. If she is immune, then there is no problem. However, if there is uncertain history of chickenpox, she is not sure whether she has had chickenpox or not, or she has had certain rash which she is not certain was chickenpox. It happened way back in childhood. So whenever there is uncertain history of chickenpox, we do the varicella zoster immunoglobulin levels. Okay, we go for the varicella zoster immunoglobulin levels in the mother. If these levels show IgG positive, that means the woman is immune and nothing needs to be done. She is okay. If she is IgG negative, that means she is not immune, and then in those cases what should be done? Varicella zoster immunoglobulin is given to the mother. So, varicella zoster immunoglobulin is given to the mother when she is not immune, and we can get to know that by doing the varicella zoster immunoglobulin levels. All right. Now, so varicella zoster is immunoglobulin, and it is best given within 96 hours, and anyways it is effective up to 10 days, but it is best effective if given within 96 hours. Right. Now, if a woman who is pregnant has chickenpox, the other situation is if a pregnant woman gets chickenpox. If a pregnant woman gets chickenpox, then how is the course different? Once she gets chickenpox, the immunoglobulin vaccine, nothing has any role. You have to remember that if the infection is at less than 20 weeks, there is 1 to 2% risk of fetal varicella syndrome. There is 1 to 2% risk of fetal varicella syndrome, right? But if the infection occurs at a gestational age of more than 20 weeks, there is no adverse effect on the fetus. Okay, there is no adverse effect on the fetus in terms of the varicella syndrome. Okay, only the infant can have shingles in the first few years of life. That is all that can happen to the newborn. So infection beyond 20 weeks is usually does not having any congenital anomaly effect on the fetus. On the other hand, neonatal infection on the other hand can happen via the transmission from an infected birth canal, right? So this neonatal infection can happen when the maternal rash or chicken pox. Neonatal infection can occur if the maternal rash occurs 5 days before to 2 days after delivery. Okay, if the maternal rash occurs 5 days before to 2 days after delivery, then maximum chances of neonatal infections are there. Then in that situation, if a mother has a maternal rash or mother has chicken pox 5 days before to 2 days after delivery, then we have to, if such a situation happens, then the newborn should get varicella zoster immunoglobulin immediately after birth. Right, immediately after birth, if such a situation happens. If it doesn't happen, then there is no need. Why? Because the mother also transmits the virus also, mother then transmits the vaccine also. So if there has been a past history of chicken pox, like chicken pox in the 3rd trimester, but nowhere near the 5 days to 2 days after delivery, no need to give varicella zoster immunoglobulin to the newborn. It needs to be given if there has been chicken pox 5 days before to 2 days after delivery. Another important doubt that you people raise sometimes is about acyclovir. Does acyclovir reduce the chance of fetal infection? No. Acyclovir is given to pregnant women. It is given to pregnant female with chicken pox for her own treatment, not to decrease the chance of transmission to the fetus. And this acyclovir will be given to pregnant female for her own treatment. Therefore, it will be given if required. Right, therefore it will be given if required, for her own treatment if required. Otherwise, symptomatic treatment for fever and rash and all those things are done. Otherwise, symptomatic treatment has to be done. Now, let's move on to the next question. Question number 86. The fetus which is partly foreign to the mother is not rejected by the mother due to immunosuppressive effects of placental hormones. This is also true, yes. Why? Because the placental hormones like your HCG, especially the beta HCG, especially the progesterone, they prevent fetal rejection. Okay, they have immunosuppressive effects, especially HCG and progesterone. Absence of HLA molecules in the villus trophoblast, that is also a true statement. And production of blocking antibodies by the mother, that is also a true statement. So all of the above is the true statement. All right. So just to give you a brief about what prevents immune rejection of the fetus and why does this problem of immune rejection actually occurs in pregnancy, is the bottom line is basically you have to understand that the human placenta is a type, or human placentation is very, very important, hemochorial. Okay, now what does this hemochorial means? This hemochorial means that the maternal blood is in direct contact with the choriole. Choriole refers to the trophoblast. So maternal blood is in direct contact with the trophoblast. Now maternal blood, how is it in direct contact with the trophoblast? Because we understood that endovascular cytotrophoblast. We understand that during trophoblastic invasion we had cytotrophoblast and syncytiotrophoblast. These endovascular cytotrophoblast actually went and invaded the spiral arterioles, right? So these endovascular cytotrophoblast, this was the endothelium. This endothelium was then replaced by the endovascular cytotrophoblast. So if these are the cytotrophoblast, they go and invade the spiral arteriole. So there was spiral arteriolar invasion, and then there was fibrinoid necrosis, and now there was a new spiral arteriolar remodeling. After remodeling, what will happen? This would be the spiral arteries, and it would be lined by endovascular trophoblast. So this is trophoblast, cytotrophoblast, which is lining the spiral arterioles, and here these are the spiral arterioles. Now this spiral arterioles contains maternal blood. You realize that now. So we understand that the maternal blood is in direct contact with the cytotrophoblast. That is why now this is maternal blood, cytotrophoblast is fetal tissue, and this is foreign tissue. Still the maternal blood is not mounting an immune response to destroy the cytotrophoblast. Why does it happen? This happens because of three factors. We'll talk about them one by one, but this is something which is something which I want to highlight here, because this is a very important basic concept about placenta. We read a lot about placenta, we read about the gross placenta, the term placenta, the placental abnormalities, and all these and other things. If you were to just zoom into the villi of the placenta, what is happening at the microstructural level is the gaseous exchange between the maternal blood and the fetal blood. And you have to understand that placenta has to be perfused by fetal blood all the time, and that perfusion has to happen. Maternal blood comes via the spiral arterioles into the intervillous spaces. Alright, so we have the trophoblast, the villi, all these are the trophoblastic villi, and these are the anchoring villi, and in between this is the intervillous space. So maternal blood is in this intervillous space, and this trophoblastic villi, here is the what is the gaseous exchange between the mother and fetus is going to take place at this level, right? Now any factor which impairs the spiral arteriolar invasion, right, and this spiral arterioles needs to become dilatable channels, and that is what is achieved by spiral arteriolar invasion. So these spiral arterioles are replaced, the endothelium is replaced by the cytotrophoblast, therefore they become non-responsive to vasoconstrictor stimuli and they become loose dilatable channels, so that blood flow can occur through them all the time, right? That is the basic requisite of placental formation. So endovascular trophoblast invading the spiral arterioles and leading to this remodeling is a basic prerequisite. Any factor which interferes with this invasion will interfere with the development of the placenta. So preeclampsia, IUGR, intrauterine growth retardation, they occur whenever this invasion is defective. So one concept we have cleared there. Now what prevents this immune rejection? Very importantly, remember just that the syncytiotrophoblast has no MHC molecule, so it can't process antigens. The cytotrophoblast on the other hand, now syncytiotrophoblast has no MHC, type 1, type 2 both, it does not have any. Cytotrophoblast, it has no MHC type 2, so it cannot mount an antibody response. It does not express the usual HLA A and B, which are the type 1 MHC, but it expresses a unique HLA, which is HLA-G. This HLA-G is responsible for the immune tolerance. Other important factor to prevent immune rejection is that in pregnancy the Th2 response is elevated more than there's a tipping of the immunomodulated state in favor of the 2H2 response as compared to the cytotoxic response is another factor, and the fourth factor is decidual NK cells. Now these decidual NK cells, again, they have limited cytotoxicity and they promote invasiveness of placenta. So these are the four important factors which prevent the immune rejection of the fetus. Now moving on to the next question. Question number 87 we have already done while we were discussing ectopic pregnancy, so we'll move ahead. Question number 88, the level of which hormone is unchanged in pregnancy? So we remember, this is a very direct question, alright, so you should remember that you can understand that beta HCG levels, they increase in pregnancy up to 16 weeks, then plateau. Prolactin consistently increases, growth hormone also increases, ACTH also increases, right? But plasma vasopressin, the levels of plasma vasopressin, they remain the same. Now, which of the following statement is true concerning galactoria? Serum prolactin is above 20 nanogram per milliliter. Okay, this is truth. Pituitary adenoma worsens the prognosis. That is also true because of all the causes of hyperprolactinemia and galactoria. We'll realize that increased prolactin or galactoria, it can have a number of causes, right? Of all those causes, if it's a pituitary adenoma, then this will worsen the prognosis as compared to the other causes of hyperprolactinemia, because the other causes are usually milder. Like what are the more important causes? Hypothyroidism and drug intake. So the hypothyroidism can be easily treated with thyroid replacement, and when we talk about drug intake, then that drug can be stopped and this hyperprolactinemia will reverse, galactoria will reverse. But if it's a pituitary adenoma, which is a tumor, it has a worse prognosis than other factors. So this is also true statement, and it is associated with menstrual disturbances and infertility. This is also true statement. So the correct answer in this case situation is 89 question is option number D. Now let us just see what is prolactin and what is hyperprolactinemia and how does it affect. So if we talk about hyperprolactinemia, right? If we talk about hyperprolactinemia, then we have to understand that hyperprolactinemia is increased levels of prolactin, right? But not all women with increased prolactin will have galactoria. Remember that all women with increased prolactin, about 1/3 will have galactoria, rest will not have galactoria. Galactoria is expressible milk production. Now, other important aspect is what are the problems with hyperprolactinemia. The problems with hyperprolactinemia is what happens, this increased prolactin, it causes decreased GnRH, and that leads to anovulation, right? And then this anovulation leads to delayed cycles, and it leads to infertility, right? So this decreased GnRH is leading to anovulation. It causes hypogonadotrophic hypogonadism. Okay, so increasing in prolactin levels lead to decrease in GnRH, all right, lead to anovulation, leading to delayed cycles, leading to infertility, leading to hypogonadotropic hypogonadism, right? So these are the usual presentations: delayed cycles and infertility. This is what the problem with hyperprolactinemia is, and galactorrhea is in itself a nuisance that can happen with hyperprolactinemia. So these are the usual symptoms: galactorrhea, infertility, delayed cycles. In addition to that, if there is a micro or a macroadenoma or a pituitary adenoma, or there is any space occupying lesion in the brain which is responsible for the increased prolactin, then that will lead to corresponding symptoms like that of headache, like that of scotomas, right, like visual field defects. So these can be there because of the location of these space occupying lesions, right. Now what are the usual causes of hyperprolactinemia? You have to understand that one very important cause of hyperprolactinemia, very important, like if this is the hypothalamus, right, and this is the anterior pituitary which is secreting prolactin, this is the anterior pituitary which is secreting prolactin, and you have to understand that this prolactin then is renally excreted, okay, it is excreted renally, right. Hypothalamus secretes dopamine. This dopamine is prolactin inhibitory factor, okay, so it inhibits the release of this thing, prolactin. So any factor which causes, so therefore you realize that any factor which will probably cause a block in this dopamine release to the prolactin, to the anterior pituitary, will lead to increased prolactin. So what are the causes? The causes are dopamine antagonists, right. So dopamine antagonists, they will cause hyperprolactinemia, they will cause increased prolactin. So you know, like metoclopramide and the antipsychotic drugs, they can cause increased prolactin. Then we have you should also remember that for this very reason what happens, that the dopamine agonists, on the other hand, they are used for treatment of increased prolactin, right. And then this dopamine agonist, the drug of choice is cabergoline. Cabergoline is now considered even safe in pregnant women, even safe in women who are trying to conceive. So cabergoline is safe in women who are trying to conceive. So no longer do we refrain from using cabergoline in infertile women, so that can be freely given over there also. Then the other important cause is a prolactin secreting microadenoma. So a prolactin secreting microadenoma or a macroadenoma, or there can be any hypothalamic tumors which are compressing this hypothalamic stalk, any hypothalamic tumors which are compressing the pituitary stalk, and thus disrupt the delivery of dopamine, right. Then that will also lead to increased prolactin. Any hypothalamic tumors which compress the pituitary stalk to disrupt the delivery. And another very important cause could be the chronic kidney disease. Chronic kidney disease can lead to, or renal insufficiency can lead to increased prolactin. Other cause is ectopic secretion. And one very important cause which I should have written up here is hypothyroidism. So another cause is hypothyroidism. So with hypothyroidism, simply treatment of hypothyroidism will correct the prolactin levels. For macroadenoma, the treatment of choice is again cabergoline, right? For macroadenoma, if they cause visual symptoms, they will need removal. If the prolactin increase is because of dopamine antagonist, that drug needs to be stopped. If it's a tumor, it needs to be removed. If it's chronic kidney disease, it needs to be treated. So we realize that the treatment of hyperprolactinemia is actually a treatment of the cause, right? The bottom line is treatment of hyperprolactinemia is actually a treatment of cause. So these are the important aspects of hyperprolactinemia. This much at least you should remember. We should also remember that when we have increased prolactin levels, because and none of these causes are identifiable, we should treat with cabergoline in a woman who is trying to conceive. All right. Now coming on to the next question. Which of the following tests is used to estimate the amount of feto-maternal hemorrhage? The answer to this question is Kleehor-Betke test, and the answer to this question is Kleehor-Betke test, feto-maternal hemorrhage. Now, feto-maternal hemorrhage and Kleehor-Betke test, let me give you a what is Coombs test, what is Liley spectrophotometry and everything. Let me just give you a very brief overview and a very quick overview of Rh negative pregnancy and how it leads to the problems and what we are talking about here, what we mean by feto-maternal hemorrhage and all these things. We will just consider that. All right, so coming to Rh negative pregnancy, and the important points with Rh negative pregnancy and these things. So now we have to remember that this Rh negative, when we talk about Rh negative pregnancy in India, we're mainly talking about the D antigen. So remember just one thing, that this gene for Rh antigen is located on the short arm of chromosome number 1. This is one important one-liner that you should remember. Another important point is, of all the red cell antigens, Lewis antigen and I antigens, they are not responsible for hemolysis. They are not responsible for hemolysis. Another important thing you have to remember is there can be an ABO incompatibility between the mother and the fetus, and there can be an Rh incompatibility between the mother and the fetus. All right. Now ABO incompatibility means that the mother is O and the baby is, most of the times it is A or B sometimes, right? So Rh incompatibility means that the mother is Rh negative and the fetus is Rh positive, right? Now remember, you have to also remember that ABO incompatibility, what are the differentiating features? ABO incompatibility is commoner than Rh incompatibility, right? It is much more commoner than Rh incompatibility. However, ABO compatibility is usually milder and it will affect the first pregnancy. However, Rh incompatibility, in which the first pregnancy is usually spared. Why? Because the IgG antibodies, it is the IgG antibodies which are formed in the second exposure or in the second pregnancy, they cause harm to the fetus and hemolysis, and the first pregnancy is spared because in the first pregnancy IgM antibodies are formed which do not cross the placenta. These IgM antibodies, they do not cross the placenta and they do not harm the baby. All right. So whenever the mother is Rh negative and the fetus is Rh positive, some amount of feto-maternal hemorrhage, this is what we are talking, some amount of fetal RBCs can enter the maternal circulation. That is called as feto-maternal hemorrhage. Some amount of fetal RBCs will enter the maternal circulation, and because they are Rh positive cells, they are going to elicit a antibody response in the mother. The first time round, the antibodies which are formed are IgM antibodies, they do not cross the placenta. It is the IgG antibodies which are formed after the second exposure that they can cause harm to the fetus. Other important factor, this feto-maternal hemorrhage, the maximum chance of this maternal hemorrhage occurring happens intrapartum during the process of childbirth, and then it happens in the third trimester. There is very rarely the chances of feto-maternal hemorrhage happening before 28 weeks, right? Before 28 weeks are almost negligible. So the maximum chances happening of this feto-maternal hemorrhage are actually intrapartum, and other than that in the third trimester. Now, the ABO incompatibility is milder and it can affect the first pregnancy itself. And very importantly, you have to remember that ABO incompatibility is usually milder and it does not usually cause fetal hemolysis. Why is it milder? Why? Because these antibodies are IgM type and they do not cross the placenta. They do not cross the placenta, right? So they are majorly of the IgM type and they do not cross the placenta. IgG type can cross the placenta. And you know what will happen, that since they already have IgM antibodies, IgG can cross the placenta. They can be, sometimes there can be IgG and they will cross the placenta even during the first pregnancy, and they can cause, they will affect the first affect the first pregnancy as well. Now other important point to remember is that whenever there is ABO incompatibility plus RH incompatibility, the severity of RH affection of the fetus is decreased. Now this is a thing that you should remember, that whenever there is RBO incompatibility plus RH incompatibility, the severity of RH affection is decreased, because whenever these ABO incompatibility RBCs, they enter the maternal circulation, they are destroyed by the anti-A and anti-B antibodies which are already present in the mother, right, before those antibodies can mount an RH response, right. So that is how the severity of RH affection is decreased. And another important point to remember, if they ask you which is the most common cause of hemolytic disease of fetus, which is the most common cause of hemolytic disease of fetus, then the answer to this question is RH incompatibility. Again, the reason being ABO incompatibility is much milder. It usually does not affect the fetus. It causes just mild jaundice in the newborn, right. It just causes a mild jaundice in the newborn. Therefore, when asked about the most common cause of hemolytic disease of fetus, the answer is RH incompatibility. However, in nature, ABO incompatibility is commoner in existence than RH incompatibility, right. Now what are the other points that you have to remember? Other points that you have to remember is whenever there is a woman with RH negative pregnancy, then you have to do the husband blood group, all right. Now if the husband blood group is, and you have to do the ICT. ICT here is the indirect Coombs test. This is a method to see whether the woman has already been sensitized or not, whether she has antibodies against the D antigen or not, and we can test the husband blood group. Now if the husband blood group is also negative, right, if the husband blood group is also RH negative, then it is okay, nothing needs to be done. It's all okay. The fetus will always be, fetus will always be RH negative, so nothing needs to be done. If the husband is blood group is positive and your ICT is negative, then ideally this ICT should be repeated every month. Ideally this ICT is repeated every month, but sometimes in the question, sometimes without of clinical constraints, we do not repeat it every month, but we have to repeat it at 28 weeks. And if at 28 weeks it is still negative, we have to give injection anti-D in the dose of 300 microgram, which is equivalent to 1500 international units of anti-D IM on the deltoid muscle needs to be given. Now this 300 microgram or this 1500 international unit, it neutralizes 30 ml of fetal blood, or that is equivalent to 15 ml of fetal RBCs. Okay, so this is an important point you have to remember, that it neutralizes 30 ml of fetal blood or 15 ml of fetal RBCs. Now once this anti-D is given at 28 weeks, what do? We deliver at 40 weeks if not already delivered, because this anti-D given at 28 weeks can only take care till 40 weeks. After 40 weeks, intrapartum needs to be covered again after delivery. We deliver at 40 weeks, and then after that we do the baby blood group. We check the baby blood group. If the baby blood group is Rh positive, then again anti-D needs to be given. Anti-D needs to be given IM 300 microgram full dose, and this should be given ideally within 72 hours, but it can be given up to 1 month. Okay, it can be given up to 1 month, but ideally it should be given within 72 hours anti-D if after delivery Rh positive child has been born. If the baby blood group is Rh negative, then nothing needs to be done. All right, so you remember here that this ICT which is given at 28 weeks and this ICT, this is the whole protocol that has to be followed. Even if we have given ICT anti-D at 28 weeks and the baby is Rh positive, we have to give this additional dose of 300 microgram to the mother after delivery of an Rh positive fetus, irrespective of whether this was given or not given, right? Any other sensitizing events need to be separately covered. So any other sensitizing events like abortion, right? Like amniocentesis, like CVS, like abdominal trauma, irrespective of bleeding, like APH, like IUD, all these sensitizing events needs to be separately covered. All right, apart from giving this at 28 weeks and this at delivery, they need to be separately covered irrespective of what was given or not given, right? So this is about Rh negative pregnancy in a woman who has never been sensitized. ICT negative means she has never been sensitized. Now if the same woman is Rh positive, if an Rh negative pregnancy, a woman is ICT positive, and we check for the husband blood group, the husband blood group is also obviously positive, then with ICT positive status we have to see that what are her titers. If the titers are more than 1:16, right? If the titers are more than 1:16, and further monitoring is done by MCA PSV Doppler, and this has to be done weekly. Remember, again, very important point to remember that nowadays monitoring for ICT positive means iso-immunized. ICT positive means iso-immunized women. So iso-immunized women, monitoring for iso-immunized women is no longer done by amniocentesis and Lilly's spectrophotometry or Quinnan graph or Lilly's graphs of any of these things. It is done by MCA PSV Doppler, which is done weekly. Okay, it is done by MCA PSV Doppler, which is done weekly. All right, if this titer is less than 1:16, example it is 1:4, 1:8, if it is less than 1:16, what we do, we will repeat it monthly or every 15 days depending upon what are the baseline, and then we reach 28 weeks. If on any time they are more than 1:16, the management will change. If they remain low, at 28 weeks there are low level static titers, it is difficult to tell whether these low level static titers are because of isoimmunization or a previous administration of anti-D. So here we can give the benefit of doubt and give anti-D to such women, right? But if the titers have crossed the critical value, the management is weekly Doppler. And then at any point in time, this PSV is more than 1.5 multiples of median. That means anemia has started to develop. And then we have to do chordosynthesis with all the preparation necessary to do blood transfusion, intrauterine transfusion to the fetus in the same sitting. And umbilical vein is sampled here, right, and we check the hematocrit immediately. If the hematocrit is less than 30%, we have to give intrauterine transfusion, right. At any point of time she is more than 34 weeks, right. At any point of time the pregnancy is more than 34 weeks. With PSV also, if the pregnancy is more than 34 weeks, it is better to deliver the baby. Right, so all this monitoring is done to reach at the max 34 weeks, and delivery is done by induction of labor, all right, not by a direct cesarean or anything. So this is what is important to remember, that MCA PSV Doppler studies are now done. If MCA PSV Doppler crosses the threshold value of 1.5 mom, that means anemia is setting in, and then we have to do chordosynthesis to go for blood transfusion, intrauterine transfusion if the hematocrit is less than 30%, and we do keep doing this repeatedly with the hope of taking the pregnancy as far as 34 weeks. All right, now very important in this concept is in India we are doing this, okay, in India we are doing this, we are doing the weekly Doppler and everything, but here we have made an assumption. The assumption that we have made here is that this isoimmunized woman is actually carrying an Rh positive fetus, all right. Only Rh positive fetus will be adversely affected. So here in this scenario, we have assumed that she is carrying an Rh positive fetus. So what they have suggested is that now the latest Williams and the ACOG, what they are suggesting is that, and the UK guidelines are also suggesting that here when we did the husband blood group, we can see whether the husband blood group, we can go for the genotype, when we can go for the genotype of the husband. If the husband genotype is negative, that means homozygous, right? And the husband's genotype can be this with Rh positive status, sorry, it could be homozygous like this, or it could be heterozygous like this. This is heterozygous. Now if the husband's blood genotype is homozygous and the mother is Rh negative, there will always be an Rh positive child, right? So if there is always going to be an Rh positive child, we go with this critical titer value, and we go with this, we go for the follow up in pregnancy. However, if the father's genotype is heterozygous, there is still a 25% chance, 1 in 4 chance, that the fetus could be Rh negative, and then that fetus does not deserve so much of MCA Doppler and extensive monitoring. So that can be, when can do the cell-free fetal DNA testing can be done in the maternal blood and fetal blood group and Rh status, and we can check the fetal blood group and Rh status and monitor only Rh status, monitor only those pregnancies in which the fetal blood group comes out to be Rh positive, and leave the other Rh negative with such extensive monitoring. Excuse me. So this is one recent change that has happened. In India, we are usually following this pattern where we are assuming that all isoimmunized women are actually carrying an Rh positive fetus, and we are monitoring them all with this MCA PSV Doppler. However, the recent guidelines, the recent Western guidelines, they are suggesting that whenever there is isoimmunized women, now this genotyping is not recommended in all Rh negative women, it is only recommended in isoimmunized women because these tests are expensive. So it is only recommended in ICT positive women where genotype of the husband can be tested and decision can be changed accordingly. Then there can be a third situation, and the last situation that I am going to discuss here in Rh negative with you today is that there could be a history of prior affected fetus. If there is a history of prior affected fetus, then in this pregnancy, then in this current pregnancy now, she does not need to have the titers repeated or anything. Monitoring will start directly, monitor directly with MCA PSV Doppler beyond 18 weeks. Okay, and then this is the only difference that one has to take care of, right? Now, in all this, in the Indian setup, what we have seen that we are not routinely testing for feto-maternal hemorrhage, but the UK guidelines say that they are not giving this full 300 micrograms of dose after delivery, right? They are in fact testing for feto-maternal hemorrhage, and they are doing that by the Kleehor-Betke test. They are doing this by the Kleehor-Betke test. So we have two types of tests, just for the comparative purposes. We have two types of tests. We have Kleehor-Betke test and app test. The Kleehor-Betke test is a quantitative test, okay? It is a quantitative test, and app test on the other hand is a qualitative test. It only tells us whether the blood is fetal or maternal, and quantitative test will give us the exact amount of RBCs. We count the RBCs here. It is an acid elution test, okay? The buffer, it is citrate phosphate buffer is here. The buffer is citrate phosphate buffer. App test on the other hand is an alkali denaturation test, right? And app test is also a bedside test. What happens that the blood that is there, when you add alkali to the blood, the blood does not hemolyze, okay? Blood does not hemolyze. That means it is fetal blood, because fetal blood is resistant to alkali degeneration because of presence of fetal hemoglobin. On the other hand, in this Kleehor-Betke test, what we do the acid, we use the citrate phosphate buffer, we take and we prepare slides, and we actually count the RBCs. So the fetal RBCs, they will retain their red color, and the maternal RBCs on the other hand, they are not resistant to acid, and they will become pale ghost cells, right? Pale ghost cells, and then they can be counted. We can count number of fetal RBCs versus number of maternal RBCs in the blood sample, and give a computed calculation of the amount of feto-maternal hemorrhage. There are various formulas for that. So that is the basis of the Kleehor-Betke test. Now coming on to the next question. In an HbS antigen positive female, which of the following statements is true? Now, transmission is mainly transplacental. This is a false statement. You should remember that this hepatitis B virus, it is a large virus, okay, and this large virus is usually not transmitted transplacentally. It mainly infects during childbirth, okay, during the process of delivery. That is when it infects the fetus. Unlike HIV, and HIV on the other hand has a considerable transplacental spread. HBV on the other hand does not have a transplacental spread. It mainly infects during delivery. So transmission is mainly transplacental. This is a false statement. Immunoglobulin should be given to the baby within 12 hours. This is the true statement. Active immunization should be done within 48 hours. This is false. This is also false, because active immunization should be done as soon as possible. Okay, this active immunization should be started as soon as possible. The zero dose of hepatitis B, the first dose of hepatitis B vaccine should be given in the labor room immediately after delivery itself, as soon as possible. Right? And immunization can be delayed up to 12 of 96 hours. That is also false. Immunization should be given whenever immunization is given, it is given as soon as possible, right? So just a few basic points about maternal maternal hepatitis infection. The whenever the mother has HBS, whenever the mother has hepatitis B and SBS antigen positive, this is what we do, this is what we test in the antenatal checkup. We test for the hepatitis B S antigen. Now for the surface antigen, now whenever a woman comes with HBsAg antigen positive status, we have to refer the woman to a gastroenterologist. Why? Because again, to a liver specialist who is going to check for the hepatitis status for her own health. Other than that, we are concerned whether she has HBe antigen positive, whether she has HBe anti-HBe positive. These are two very important characteristics we have to see. We have to see for her HBe antigen, we have to do her anti-HBe, we also do her anti-SBC. Okay, we also check for her anti-HBC to see whether she is in which phase of chronic hepatitis is she. Is she in chronic active hepatitis, right? So that is more of the medical the management there, and the classification there is just like any other medicine patient. Okay, so I will not go into the details of that. I will talk about what is relevant to pregnancy status. So whenever there is HBsAg antigen positive, we see whether she is HBe antigen positive or not, if there is anti-HBe positive or not, because what is important is the risk of transmission to fetus. Risk of transmission to fetus is drastically increased if she is HBe positive. So if there is HBs antigen plus there is HBe antigen positive, then the risk of transmission to the fetus is around 90%. All right, just with this HBe antigen being positive, and if it is HBs antigen positive, mother is HBs antigen positive and anti-HBe positive, then the risk of transmission is around 20 to 30%. So that is what is important to remember. We are mainly concerned with these two values, right? Other important thing that you have to remember is that the treatment of the mother goes on. There is hardly any transplacental passage of the virus. The main transmission happens during the period of delivery, and the way to counteract that is to give the fetus, to give the newborn. The newborn is given IgG immunoglobulin and is given vaccination as soon as possible. Okay, as soon as possible. They should be given at least within 24 hours. Ideally they should be given within 24 hours. They should be given as soon as possible. That is one precaution that has to be taken. So this is the only thing that we can do for such women. Other important thing is breastfeeding. Very, very important. Remember, breastfeeding is not contraindicated. Breastfeeding is allowed. So these are the three-four important points about hepatitis infection in pregnancy. So whenever hepatitis infection in pregnancy, we see whether HBe antigen or anti-HBe antigen are positive or not. That will help us determine the risk. Whatever be the type of hepatitis, active chronic hepatitis or not, mother's treatment will depend upon her degree of chronicity for hepatitis B infection. As far as the newborn is concerned, the newborn will require immunoglobulins and vaccination as soon as possible, and breastfeeding is not contraindicated. Moving on to the next question. Question number 92. Sarcoidosis in pregnancy. Sarcoidosis in pregnancy, remember that there is no change in sarcoidosis in pregnancy. Now these topics, this question here, you don't have to I'll just give you an important bit to be able to answer this question, that you have to remember that in pregnancy I told you that Th2 responses are much highlighted than the Th1 responses, right? So any diseases which are dependent upon the humoral immunity, they are going to worsen, like SLE worsens. Now SLE worsens in equal proportion, like SLE 1/3 remain the same, 1/3 will increase, and 1/3 cases will decrease in severity, right? But mainly SLE worsens because of this reason, that the Th2 response is are heightened, and SLE again depends upon the formation of antibodies. So that is why any disease which pertains to the humoral immunity will worsen in pregnancy. On the other hand, rheumatoid arthritis, which depends upon the Th1 response, it actually improves in pregnancy. Okay, it improves in pregnancy. So we can remember these 2 points. Sarcoidosis on the other hand usually has been seen not to change in pregnancy. Then another important point is epilepsy. We have to remember about one more important thing about medical illness, epilepsy. Frequency of epilepsy will remain epilepsy 1/3 cases the frequency remains the same, and in 1/3 cases it will worsen, and at 1/3 cases it will actually improve. The seizure frequency will actually improve, and it mainly remains the same, or it actually improves again in those cases where a woman has been seizure free. If the woman has been seizure free for, let's say, past 8 to 9 years, then it is more likely then that she will remain seizure free during the entire duration. All right, especially if seizure free for past 8 to 9 years, there are more chances for her remaining seizure free. So just a few medical conditions and whether they increase or decrease in pregnancy, that is what you have to remember. So rheumatoid arthritis, remember, it improves in pregnancy. Epilepsy, 1/3 cases remain the same, 1/3 cases they will be worsening of seizure frequency, and 1/3 cases she will improve actually. So especially if seizure free for past 8 to 9 years. SLE overall worsens in pregnancy, especially if there have been active disease, especially if the disease has been active in the recent period. Now question number 93, which of the following hepatitis viruses have significant perinatal transmission? And like we discussed, it is hepatitis B virus, because whenever we are talking about neonate, we are talking in terms of hepatitis B. Now this question does not specifically need any other explanation. Question number 94, a 25-year-old, 94, okay. Now a 25-year-old comes in emergency with 2.5-month amenorrhea and abdominal pain and bleeding for vagina for 1 day. Pain and bleeding, 2.5-month amenorrhea, vitals are stable, mild bleeding through os. On vaginal examination, the uterus is 10-week size, os is open and admits 1 finger. Now uterus 10-week size is approximately 2.5 months of amenorrhea is approximately 10 weeks. So the uterus size is same, so the likely diagnosis is inevitable abortion. The likely diagnosis is inevitable abortion. Now I just want to give you a flow chart about how we can answer such questions whenever they come. All right, so we can have the various clinical presentations of abortion, because what kind of questions they will frame around it. Again, like similar ways, they are going to give you a clinical presentation and they are going to ask you what is the diagnosis, or they are going to ask you what is the treatment. So clinical presentation of abortions is same as far as first or second trimester abortion is concerned. It does not depend upon that. So irrespective of the period of gestation, the clinical presentation of abortion remains the same, whether first or second trimester. So we have threatened abortion, we have inevitable abortion, we have incomplete abortion, and we have something called as complete abortion. And missed abortion was a term which was used earlier, but now I will talk about it separately because that term has been discarded. Now we are mainly dealing with early pregnancy loss, so we'll come to that. We'll talk about the new improved terms, not the old discarded terms. So we have threatened, inevitable, incomplete and complete abortion. In threatened abortion, there would be the bleeding PV is going to be very mild. There's going to be probably only spotting. In inevitable, the bleeding is going to be slightly more. In incomplete, the bleeding PV would be much more. There could be plus minus shock. Incomplete, the bleeding PV, there will be history of bleeding PV will be there, and significant bleeding could be there, which has now stopped. There could be history of passage of a fleshy mass also, but this is about the clinical history. Considering the physical findings, you remember that in threatened abortion, the os will be closed and the uterus size is going to correspond to the period of gestation, right? In inevitable abortion, the os is going to be open and the uterus size is going to be equal to the period of gestation. In incomplete, the os is going to be open. There can be period of conceptions, POCs in the vagina, they can be felt in the vagina, and the uterus size could be decreased or it could be the same, right? When we talk about complete abortion, the os is now going to be closed and the uterus size is going to be much decreased, right? So this is about the clinical presentation. Secondly, when we have a case of threatened abortion with os closed, with uterus size equal to the size of POG, we confirm by ultrasound. And on ultrasound, what do we confirm? We confirm the cardiac activity. Cardiac activity is present. We confirm everything is okay with the pregnancy. The management is conservative. Conservative does not mean any medical treatment. Conservative means just avoid exertion, avoid coitus. And conservative does not mean progesterone. So progesterone, giving progesterone here has no definite role. Okay, progesterone, though given very openly, it is not an evidence-based medical practice. Inevitable abortion, we have to see cardiac activity would be plus minus, it doesn't matter. We have to let it progress. We let it progress and we intervene only and only if the bleeding is excessive, all right. Now, if the bleeding is excessive, how will we intervene? We will have to speed up the process of evacuation. Like in incomplete abortion, how do we manage? We will speed up evacuation, and speeding up this evacuation, if we are speeding up a first trimester abortion, we will have to use DNC, we can use suction evacuation. If we have to speed up a second trimester abortion, we might need to use oxytocin, we might need to use prostaglandins depending upon that. So the scenario where we are will differ. So ultimately we need to speed up evacuation. With complete abortion, we just need to confirm whether on ultrasound whether the cavity is empty. Ultrasound will confirm that the cavity is empty. If the cavity is empty, nothing needs to be done. If the cavity has some retained bits, then if she is symptomatic, then only it needs to be removed, otherwise nothing needs to be done. So ultimately remember that if it's complete abortion and the diagnosis is confirmed on ultrasound, then nothing needs to be done specifically. Then remember that a term which was called as missed abortion, now the term has discarded and we have a new term which is called as, we call as early pregnancy loss. And there are certain ultrasound features of early pregnancy loss. When do we diagnose early pregnancy loss on ultrasound? Whenever the gestational sac is more than or equal to 25 mm in diameter, and there is no fetus inside, there is no fetus or there is no yolk sac inside, then that means it is an early pregnancy loss. If there is a CRL of more than or equal to 7 mm and there is no cardiac activity, then that means it is an early pregnancy loss. So this is the new diagnosis, new diagnostic criteria of early pregnancy loss. Supposing for example there is a pregnancy at 6 weeks and the CRL is, let's say, 5 mm, right? What is the next step? The next step is not to consider, and there is no cardiac activity, the next step is not to consider consider it as a threatened, consider it as early pregnancy loss, but the next step here would be to repeat scan after 1 week or 2 weeks depending, and we will repeat scan to see, because the CRL has to be more than 7 mm or equal to more than 7 mm with no cardiac activity to be diagnosed as early pregnancy loss. So that is just the difference here. We will move on now to the next question. Question number 95. Hysteroscopic image below shows, now this is a very excuse me. Now this is a very clear-cut picture here. We can see the hysteroscopic image here. This hysteroscopic image below shows an, now this is an endometrial polyp, all right. Now by just looking at it, now some people could be confused in this question as to it being a fibroid, all right. Now the reason it is not a fibroid is that in the option it is not given a fibroid polyp. Sometimes this hysteroscopic image could be of a fibroid polyp also. Now just by looking at it on hysteroscopy and then to be able to tell if it is an endometrial or it is a fibroid polyp, it sometimes becomes difficult. Here, since fibroid polyp is not given, the answer is clear-cut endometrioid polyp. Other than that, if you were to differentiate between a fibroid polyp versus an endometrioid polyp, fibroid polyp looks a more fleshy, right? On the other hand, the endometrial polyp is going to be a little more friable and it is not going to be fleshy. Now this, just by looking at this, right now in this question I will mark an endometrial polyp because the fibroid polyp is not given as an option here in this case. However, just by looking at the polyp we can probably get an idea whether it is a fibroid or endometrial polyp. Ultimately the diagnosis has to be made by histopathology, has to be confirmed by histopathology. Fibroid polyp looks a bit more fleshy in appearance and endometrial polyp looks a more friable in appearance. Now moving on to the next question. The most common, it's a 97 question, the most common symptom of ectopic pregnancy. This has also been done. We have done this question. Question number, this has been done, so we will not deal with this. 96, let's come on to question number 96. Piegelberg criteria is used for the diagnosis of ovarian pregnancy. Now this is something that you have to remember, at least remember the various criterias. We have the, let me just tell you very important bits here. We have the Studiford criteria. Studiford criteria is for primary abdominal, not secondary, okay. It is for primary abdominal pregnancy, that is the Studiford criteria, primary abdominal pregnancy, Studiford criteria. And if at all you have to remember something about primary abdominal pregnancy, you should understand that in this primary abdominal, both tubes and ovaries, they are normal. That means that the pregnancy was in the abdomen to begin with. It is not like it was in the tube earlier and after rupturing the tube or after being in the ovary, it went ahead and implanted elsewhere in the abdomen. That is what is secondary abdominal pregnancy. So in a primary abdominal pregnancy, both tubes and ovaries are normal. There is no uteroperitoneal fistula. There is no uteroperitoneal fistula, so it's not like it has perforated the uterus and come out. So there is no other source of abdominal pregnancy. Very importantly, Braxton Hicks Braxton Hicks, they are absent in a primary abdominal pregnancy. Very, very important. And primary abdominal pregnancy always needs to be, whenever identified, it needs to be treated by laparotomy. There is no other option to go about it. For ovarian pregnancy, again the criteria is Spiegelberg. In Spiegelberg, you have to see that the ipsilateral tube is intact and the location is that of the ovary. The location of the pregnancy is that of the ovarian location. So we have to see that the ectopic is connected to the uterus by the ovarian ligament. So that will signify that actually the ectopic is in the location of where the ovary should be, and ovarian tissue is found histopathologically in the ectopic specimen, right? Ovarian tissue is found in histopathologically in the ectopic specimen. This is what is Spiegelberg criteria for ovarian ectopic. Studiforth criteria is for primary abdominal pregnancy. So these are two important criteria. Then we have the cervical ectopic. With cervical ectopic, on the other hand, there was to be a criteria which was called as Rubin's criteria. It was used in the past, it is not longer used anymore. Now we have a new criteria, better one, which is Parman's criteria. Now this Parman's criteria is a better criteria. It's more commonly used these days for cervical ectopic. There are 5 characteristics in Parman's criteria. So you have to understand that this is the uterus and this is the cervix, right? And the cervix has ectopic pregnancy is in the cervix, and this internal os is closed, all right, and the bleeding is come, and this cervix harbors the pregnancy, and that is why the cervix becomes ballooned. It can become ballooned to such an extent that it becomes almost larger or equal to the size of the uterus. Cervix becomes enlarged, the uterus is smaller, and we have to appreciate that in this case, since the location of the pregnancy is too much down below in the endocervix, there is going to be bleeding, and the cause of contractions, the cause of pain during abortion is because of uterine contractions. Now since the uterus is empty, there is no contractions, and therefore cervical ectopic usually presents with bleeding without pain, right? Bleeding without pain. So here we remember two things, that the pain which happens in the process of abortion happens because of uterine contractions. Since the uterus is empty, there is bleeding but there is no pain. There is enlarged soft or enlarged cervix which is equal to or more than in size to the uterus. Then the POCs, they are confined to the endocervix. The internal os is closed. The internal os being closed establishes the fact that this pregnancy has been here. It is not like it has travelled from above and lodged in the endocervix, alright. So internal os is closed and the external os is partially opened. External os is partially open. This is the criteria of Parman's criteria for cervical ectopic. POCs confined, internal os closed, external os partially open. These will be confirmed on ultrasound, and obviously you have to see bleeding without pain is a clinical finding. So this is a clinical plus ultrasound criteria. This is a has clinical plus ultrasound features which will suggest whether we have cervical ectopic or not. Now moving on to the next question. Air in the urine bag after laparoscopic hysterectomy is due to. Now see, this is a question which is not probably gynae but just a surgical bit of question, and this is a very nice question in the sense that if there is a air in the urine bag, why should air be in the urine bag? There is no other way that air should be in the urine bag except for the fact that it becomes a bladder injury. Because what will happen once the bladder gets injured during laparoscopic surgery, the abdomen is distended with gas. Carbon dioxide is used to distend the abdominal cavity. Now when the bladder injury happens, bladder has been perforated, bladder has been incised, all these kind of injuries, then what will happen? The air from the peritoneal cavity will move into the bladder, and then that air will now enter into the urine bag which is connected. So obviously whenever there is air in the urine bag, it's not a normal finding. Bowel perforation will not lead to an air, bladder injury will lead to air in the urine after laparoscopic hysterectomy. Question number 99, which is not an indication for a classical cesarean section? Now, not an indication for a classical cesarean section, the answer is term breach. Why would you need to do an cesarean section, a classical cesarean section, a term breach? There is no such indication. Now, remember that for classical cesarean section or upper segment cesarean section, the only two valid and absolute indications are invasive cervical cancer, and the second indication is a morbidly adherent placenta in the lower segment, where we want to go for the classical cesarean section. These are the only two absolute indications of performing a classical cesarean section. Other than that, sometimes because of repeated cesarean sections, there can be dense adhesions in the lower abdomen, and it becomes very difficult to visualize the lower uterine segment or to reach the lower uterine segment. By reaching the lower uterine segment can entail incisional or cautery damage to the bladder there. So therefore we might go for a classical cesarean section sometimes. With transverse lie also we do not always perform. So don't think that with transverse lie one always performs a classical cesarean section, and do not think that when you cannot visualize the lower uterine segment you perform a classical cesarean section. It's not like that. If you don't see the lower uterine segment, we try to reach as far down safely as possible. That is what we usually try to do. With the transverse lie, we do not always go for a classical cesarean section, but sometimes the incision can need to be classical, and this also especially with dorso anterior, that means the back anterior. So imagine if this is the fetus, if this is the uterus and this is the fetus with back anterior. Now when fetus is with back anterior and we have given incision in the lower segment, we have no knobby structure to grasp the fetus and deliver the baby with, right? So we need to give an incision probably here, and then it becomes easier to reach the limbs of the fetus. However, in a transverse lie, when this is the baby's head, supposing this is the incision here, this is the baby's front, baby's limbs are here, lower limbs, upper limbs, both limbs are here. We give an incision here, reach with our hand, grasp the limb and take out the baby. So whenever the baby is dorso anterior like this is dorso anterior, back anterior, whenever it is dorso anterior, it can become difficult to deliver the baby through this transverse incision, because it becomes difficult. We put a hand inside from here, but we have no limb to grasp. Therefore, sometimes we might need to give an incision here. Now that is the prerogative of the surgeon to decide what he wants to do. Other than that, transverse lie, when the back is posterior, it is fairly easy. We give an incision in the lower segment, reach out, put the hand inside, grasp the limbs and deliver the baby. It is easier. With premature breech, sometimes we might need to do a classical cesarean section. Why? Because in a preterm breech, what can happen? The lower segment might not be formed at all. So when the lower segment is not formed at all, then we have no space to give a transverse incision. Alright, because of lack of space to give a transverse incision, we might need to give a classical incision. So these three are not absolute indications of classical cesarean, but they there are situations where a classical incision might be needed. A classical incision is always used in invasive cervical cancer, morbidly adherent placenta. In term breach, it's just not an indication at all. Alright. Now, question number 100 I will do in the other set when we are talking about gynae-oncology. Right now, let me just move on to question number 101. Now, which of the following FLAC ratio strongly suggests fetal malnutrition? The answer to this question is 23.5. Usually what happens, usually the femur length to abdominal circumference. What happens in malnutrition, fetal growth restriction? It is the abdominal circumference which is altered. Femur length is relatively constant. This ratio FL is to AC is usually constant from 20 weeks to term. This ratio is around 22. This ratio is around 22 and it is usually constant. With fetal malnutrition, abdominal circumference decreases. When abdominal circumference decreases, the FL to AC ratio is going to increase, and when it is beyond 23.5, it signifies fetal growth restriction. Right now, I just want to discuss the very important obstetric aspects of fetal growth restriction, right? Because fetal growth restriction, the obstetric aspects, and very importantly the Doppler aspects. So just come to think of it, whenever there is a fetus which is suspected of fetal growth restriction, that fetus is suspected for fetal growth restriction. Why? Because of clinical examination, because of clinical findings. On clinical findings, the fundal height or the symphysiofundal height appears smaller than the period of gestation. That is how the first suspicion of suspected fetal growth restriction is made. When such a suspicion is there, then you have to understand that this growth restricted fetus or smaller fetus could be, this is called as small for gestational age. Small for gestational age. This fetus could be small for gestational age. That means it is less than 10th centile for that gestational age. This small for gestational age could be pathologically growth restricted, or it could be constitutionally small. Okay, majority of such babies are actually constitutionally small. Few are pathologically growth restricted. How do we know if it is a pathologically growth restricted? How do we differentiate? We differentiate by performing an ultrasound. What do we do in an ultrasound? We will see the estimated fetal weight, we will see the individual parameters like FL, AC, BPD, head circumference, and we will see the Doppler findings, right? Umbilical artery Doppler. Which Doppler? Umbilical artery Doppler. So on suspected IUGR, we have to do an ultrasound, and we have to, a single ultrasound will not show us anything. This ultrasound for growth needs to be repeated 3 to 4 weeks to see for growth. So if in the intervening 3 to 4 weeks growth is documented, that means it is a constitutionally small baby which is growing at a normal pace. So it is the slope of growth which is important, right? Slope of growth is which is important. If the growth is lagging, or if there is Doppler changes, then we are diagnosing, or there can be oligohydramnios. Oligohydramnios suggestive of uteroplacental insufficiency. Then we are, this is what happens when the fetus is actually growth restricted. That means it is a pathologically growth restricted fetus. Okay. Now, in this ultrasound, we get to know about the estimated fetal weight, the FLAC and these parameters, and the Doppler, right? So now you have to understand one thing, that what is the single best parameter. Supposing if they ask you this question, that which is the single best parameter, the single parameter used for diagnosis of IUGR. Singly which parameter is important? That means if it is FL or AC, or is it BPD, or is it head circumference, then the answer is abdominal circumference. So abdominal circumference is the single parameter used for diagnosis of IUGR. However, the diagnosis of IUGR is actually going to be confirmed by the serial ultrasonography, which is very important. Serial sonography for growth. Serial sonography for growth is actually going to make the diagnosis of pathological growth restriction, or we can have Doppler changes, which will make the diagnosis of pathological growth restriction. As far as the fetal outcome is concerned, that means of all IUGR fetuses, if an IUGR fetus is there, what determines the fetal outcome? Now, what determines the fetal outcome? The main important point is the gestational age at delivery. The main is gestational age at delivery, or the maturity, that will determine the fetal outcome. After this, it has to be the umbilical artery Doppler, fetal Doppler changes, umbilical artery Doppler changes, which will determine the fetal outcome, and the estimated fetal weight, which will ultimately determine the fetal outcome. So these are the main factors on which the fetal outcome will depend: the gestational age at delivery, the Doppler changes, and estimated fetal weight. And if they ask you this question, that which method is used for monitoring IUGR pregnancy, for monitoring IUGR pregnancy, we use umbilical artery Doppler, not any other Doppler. We use fetal umbilical artery Doppler. Now we have to understand that what happens in the fetus. Umbilical artery takes deoxygenated blood from the umbilical artery takes deoxygenated blood from the fetus to the placenta. Right now, the placenta, fetal heart is pumping this blood, and it is going via umbilical artery to the placenta. Fetus heart pumps blood in the umbilical artery in both systole and diastole. As pregnancy advances, what happens is that whenever there is flow in systole when the heart pumps, and there is flow in diastole. There is flow in systole and there is flow in diastole. Flow in systole and there is flow in diastole. So this is called as the systolic and diastolic flow. Alright, so you have to understand that the fetal heart pumps blood during systole, and in diastole the forward flow of blood is maintained. How? Because the placenta is a low resistance circuit, isn't it? The placenta is a low resistance circuit. The placenta is a low resistance circuit, and as the placenta develops and matures with gestation, the resistance should ideally keep on falling, and this forward flow during diastole is maintained. So as pregnancy advances, the forward diastolic flow increases. So when the forward diastolic flow increases, the SD ratio decreases. So SD ratio, the systolic is to diastolic ratio at 30 weeks is around 3, and at term the systolic diastolic ratio is around 2. Right now, what will happen if there is high resistance in the placenta? If there is high resistance in the placenta, like seen in preeclampsia, like seen in whenever there is high resistance for whichever reasons which are causing uteroplacental insufficiency. Whenever there is uteroplacental insufficiency, there is high resistance, and we can see that what happens with high resistance at this level, the fetal heart is able to pump blood in systole, but in diastole what happens? The flow decreases. So there is diastolic flow decreases. and when diastolic flow decreases, SD ratio increases, SD ratio increases. So what will happen here? What happens here is systolic flow and diastolic flow, systolic flow and diastolic flow, systolic flow and diastolic flow. So we saw that systolic flow and diastolic flow is decreasing, right? Ultimately there will come a time that when there will be only systolic flow and diastolic flow will be absent. So this is flow in systole and diastolic flow is absent. This is called as absent end diastolic flow. This is called as absent end diastolic flow. So ultimately when majority of the uteroplacental circulation is compromised, that is what happens when absent end diastolic flow is reversed, is happening. Then ultimately what will happen, that there is so much damage to the uteroplacental circulation that there is actually reverse resistance is so high that actually there is reversed diastolic flow. This is called as reversed end diastolic flow. Now the decision to time the delivery depend upon the Doppler characteristics. So as long as the SD ratio is increasing, what we can do, we can keep monitoring, monitor frequently, and we try to take the pregnancy till term. We try to take the pregnancy till 38 weeks at least, alright. Monitor more frequently and continue the pregnancy. Try to take it as far near term as possible. We try to take it till 38 weeks. Whenever there is absent end diastolic flow, with absent end diastolic flow, if the pregnancy is more than 34 weeks, we should deliver. If it is reverse end diastolic flow, then there should be deliver, and usually cesarean section is preferred because such a baby will not tolerate the stress of labor. Deliver irrespective of period of gestation. Okay, deliver irrespective of period of gestation with reverse end diastolic flow. So these are the important things for you to remember. Now UK guidelines and the new, not the American guideline, not Williams, this is not said by Williams, but the UK guidelines sometimes say that, you know, even with absent and reverse, and when we are far away from term, we can use other Doppler characteristics to time delivery. Alright, now what are those other Doppler characteristics of pre-terminal changes? What happens, you can see that when the fetus heart fails, when the fetal heart fails, what will happen? When the fetal heart fails or there is fetal myocardial ischemia, then sometimes, you know, what will happen after reverse, this will happen usually after this reverse end diastolic flow or absent end diastolic flow, when the fetal heart change fails or when there is myocardial ischemia, or it could be asked in another way that which are the pre-terminal changes. Which are the pre-terminal changes? Pre-terminal change means when such changes in Doppler start coming, they signify impending fetal death. Right? Anyway, the question could be there, what are the changes which signify that the fetal heart fails? What are the changes which signify fetal heart myocardial ischemia? What are changes which are pre-terminal? What are changes which signify impending fetal death? Those are reversal of flow in ductus arteriosus and the other is umbilical venous pulsations. Now this is what is you have to remember, which is important as far as the IUGR is concerned, that you remember the concept of what is IUGR, you remember that it is the Doppler changes which we are using to time the delivery, right? So for monitoring the IUGR pregnancy, it is umbilical artery Doppler. For timing the delivery also, we are using umbilical artery Doppler mainly, right? For fetal outcome depends upon gestational age, Doppler changes also depends on estimated fetal weight. To make the diagnosis, single parameter we are using abdominal circumference, otherwise we are going for serial sonography for growth, right? So this is the basic bit that you have to remember about IUGR, and then you have to remember these Doppler characteristics about what is absent, what is reversed. Simple figure based and identification of the Doppler parameter could be asked. And remember that you cannot, by just looking at the graph, say if it is SD ratio is increased, because this is computed, all right. Just by looking at it you cannot say. So usually it will be identification between absent and reversed, which will be there. Then you have to remember these are the pre-terminal Doppler changes that are there, which you need to identify. Moving on to the next question. Following delivery, uterine fundus lies about 5.5 inches above symphysis pubis. Now this is a very direct question, all right. And even if you don't remember the exact 5.5 inches, you should remember that following delivery, the uterine fundus, just comes to lie just below umbilicus, right? Now, just below umbilicus, obviously, if something is just below umbilicus, it is definitely not 10.5 or 8.5 inches above pubic symphysis. And it is by exclusion 5.5 above pubic symphysis that you have to remember. 5.5 inches is around 13.5 centimeters above the symphysis pubis, or just below the symphysis pubis. And then you have to remember that this uterus basically involutes and contracts to return back to its normal position, and the muscle fibers, they shorten and they retract. The muscle fibers, they shorten and they retract, right? And it becomes a pelvic organ by 2 weeks. By end of 2 weeks it becomes a pelvic organ, right? Now the uterus involution takes complete 6 weeks. It takes in overall 6 weeks overall is the time taken for involution of the uterus, all right. So it becomes a pelvic organ by 6 weeks, 2 weeks, but the overall involution takes place 6 weeks. Specifically the placental site involution, takes place around 6 weeks. And you have to remember that the weight of uterus after 4 weeks of delivery, the weight of the uterus is somewhere around 100 grams, okay, somewhere around 100 grams after 4 weeks of delivery. Now, question number 103 has already been done when we were talking about ectopics, so we will move on ahead with the next question. Now, in abdominal hysterectomy, the first clamp is applied, which includes the cornual structures. Now this is a simple question, a conceptual question. You don't need to mug up such questions. You have to remember that when we are doing abdominal hysterectomy, a uterus has to be gotten rid of its all supports, and you see this is the round ligament. There is the, if you see from behind, this is the ovarian ligament connecting with the ovary, and then in the middle there is the tube, there is the tube in the middle. This is the tube and this is the ovary. This is the ovarian ligament and this is the round ligament, right? And then this is the transverse cervical. Similarly, you have the uterosacral ligaments and this will be the vagina. So when you have to free the uterus, and you have to also remember one more thing, that there is another ligament which connects the tube and this ovary here. So you can diagrammatically represent it here. There is another ligament here which connects the tube and the ovary to the lateral pelvic wall. That is the infundibulopelvic ligament. That is the infundibulopelvic ligament. Now I think this is getting a bit messy. Let us just draw it here. So supposing there is this uterus and there is this cervix, transverse, this is the cardinal ligament or the transverse cervical ligament or the McEnroth's ligament, right? Then posteriorly there is going to be the true uterosacrals, okay, uterosacral ligament. Then this is the tube, there is a round ligament, this is the round ligament, this is the tube. There is going to be an ovarian ligament connecting the uterus to the ovary, and there is going to be another ligament which is connecting the tube and the ovary to the lateral pelvic wall. This is the infundibulopelvic ligament which connects the ovary to the lateral pelvic wall, right? And here is going to be the vaginal cuff. Now it is very simple. When you are approaching from the abdominal cavity, you are putting the first stitch at the round ligament, then we are putting the clamp at the cornual structures. This is the first structure we are going to remove. Then we are going to apply progressive clamps, and then we will include the uterosacral and the cardinal later on, right? So whenever we are doing abdominal hysterectomy, what is the sequence of clamp? Sequence of clamp is the cornual structures, then the uterine artery, and then the uterosacral and cardinal ligament. They are mostly, they come together in the same clamp, sometimes they come together separately, but this is the usual sequence. In a vaginal hysterectomy, on the other hand, the sequence of the clamp is reversed. So it is the uterosacral and cardinal ligament complex, then it is the uterine artery, and then the last clamp is on the cornual structures. So this is the sequence of clamps here, this is the sequence of clamps here. Very important point another, that if you have to keep the ovary, when you have to preserve the ovary, when we have to keep the ovary inside the abdomen, the clamp is applied on the ovarian ligament. Ovarian ligament is clamped. Okay, and when we have to remove the ovary, that means we have to do an oophorectomy, then clamp, this has to be removed. Then the infundibulopelvic ligament is clamped. Okay, so these are two additional important points to remember, that when we have to preserve the ovary, the ovarian ligament is clamped, and when we have to remove the ovary, when you apply clamp in the infundibulopelvic ligament, ovary comes out with the specimen. So this is another important fact, this you have to remember about this vaginal hysterectomy and versus abdominal hysterectomy.